Traditionally, the no stent zones were the common femoral artery, ostial superficial femoral, and profunda artery, the popliteal artery, and some people would even include distal bypass graft anastomosis. And that's part of the reason that you've been taught that is this is a slide that shows you stent fractures in the SFA. And they're typed from type 1 to type 4. Type 1 is single strut fracture. Type 2 is multiple stent strut fractures. And then type 3 is complete linear stent fracture, but without displacement. Now, we know from some of the older literature, even back in 2006, that stents are better than PTA. So part of the impetus to continue to put stents in the SFA is that stenting is better than just doing balloon angioplasty. And for the popliteal artery, there is a fear of stent fracture, and it's because of elongation or overlap of stents, the high biomechanical stresses that are operable in the popliteal area, and then the risk of restenosis. And you've all seen images like this where you bend the leg or you bend the knee and you see what happens to a stent that's placed in the popliteal region. And some of you may have even seen stent pictures like this where the stent is completely fractured because of bending the knee. Now, stent placement versus balloon angioplasty in obstructive lesions in the popliteal area. This is a study from 2013, but I think it's important because it looks at patients that were randomized to either stent or PTA. And again, what we see is that the patients that received a stent did better than the patients that received PTA. And also the event-free survival was better in the stent group versus the PTA group. So the concerns of putting a stent in the popliteal area, although real, may have not been realistic in a real-world patient population. And provisional stenting had the same one-year patency as primary stenting, so provisional stenting should be considered over primary stenting when we're dealing with the popliteal, and that sort of makes sense. Why put something in popliteal if we don't have to? Part of the issue that we've had is that the standard nitinol stents, you can see on the far right-hand side what happens to that stent when it's spent. But the newer generation of stents, like the interwoven stent, the superior stent, you can see that it maintains its shape even though it's bent to an extreme angle. And this stent resists compression. On the far panel, you see what happens to a standard nitinol stent with 20 pounds of pressure applied and what happens to the superior stent on the near image. It maintains its oval or its circular shape. And this stent has also been found useful in calcified lesions, which has been one of the Achilles heels of interventional procedures. Now, this is all in the setting, or we have to keep in mind that now we have another technology called drug-coated balloon angioplasty, and this is something that's being used in the popliteal region. And it may turn out that this might be a better choice than putting a stent, but certainly for patients that have dissection or have other heavily calcified lesions, we don't know what the data is going to show long-term. The other area that was concerning as far as stenting and what you've all been traditionally taught, do not put a stent in the common femoral artery under any circumstance. This is a study that looked at exactly that, putting stents in patients with common femoral artery stenoses. And it looked at patients, not only just the simple run-of-the-mill patient that you might see walking into the clinic, but these are patients that had significant comorbidities, which made them at extreme or at higher risk for having surgical intervention. And if we look at the Kaplan-Meier curves here, we can see that surgery and stenting were very similar in their outcomes, even out to 24 months. So these results supported stenting over surgery for morbidity and mortality in particular patients. And it also emphasized that the fear of stent fracture with hip flexion was not relevant. In conclusion, we can certainly say that clinical situations may necessitate endovascular treatment in traditionally no-stent zones. In the area where I practice, it's not uncommon to have a patient that may be over 200 kilograms. Now, certainly a 200-kilogram patient doesn't really have a groin, so trying to find a femoral artery or thinking that you're going to do a simple endarterectomy, which is how my surgical colleagues usually describe it, is not a case, or it's not option. Endovascular technologies have made stenting in the popliteal artery reasonable with good outcomes and patency. And certainly with using stents like the superior stent, we can get results that are both immediately successful and long-term durable. But again, this all has to be taken into consideration with the patient population that you're dealing with. For example, I had a 18-year-old patient who was an American football player who had come from another institution after presenting with leg pain and had a superior stent placed in his popliteal artery. And I think most of you out in the audience will be able to figure this one out before, we even got to the final answer. But this was popliteal entrapment, and the patient, once he was referred to me, had an angiogram, but was referred to surgery to have the popliteal entrapment released. So you have to know the history, and you have to take all of that into consideration before you attempt any of these procedures. Just because you can mechanically or mechanistically get a stent or a balloon in a certain place doesn't mean that that's the right thing to do. On the other hand, by the same token, patients have to be individualized, and working together with your surgical colleagues is better than trying to take care of the patient and not consider the other options. So sometimes there are hybrid procedures, sometimes there are procedures that you can do, or sometimes it's better done by your surgical colleagues. So I would emphasize that, are there no stent zones? As far as I'm concerned, I think everywhere you can put a stent, so that the idea of no stent zones doesn't exist. I don't think you should put stents in all of these places in every single patient. So you have to individualize, and you have to do what's best for the patient. And certainly the common femoral and profunda femoris arteries may be treated with endovascular therapy instead of surgery in selected cases. My group published in, believe it or not, in 2001, we published stenting or angioplasty of the profunda, and you can imagine the heat that we got from that back then. But certainly, I think with the newer technology and with using your brain, we can take care of these patients and give them the best long-term outcome. Thank you very much.